Good evening. Thank you very much, everybody, for joining us tonight for this discussion of the results of the study of which you've been the participants and the volunteers and the incredibly generous individuals that over the last 6 months have provided blood samples to help us to understand first the prevalence of the infection in the UK community, which has been very important for a lot of the government planning to help deal with the pandemic. But also, as you'll hear later in the evening, helping us to understand better what happens after infection and the potential for prolonged antibody responses. My name is Rory Collins. I'm the principal investigator of UK Biobank, and it's a great opportunity to thank you personally, all the UK Biobank participants who are here, who joined the study between 2006 and 2010, 10,000 or so of you from the 500,000 people across the UK that have been in that study since joining, and to the 10,000 or so of your children and grandchildren who have agreed to take part in this study of COVID-19 and infection from the SARS virus. So again, thank you very much. On the slide that's showing at the moment is intended to orientate you a little bit to how you can use the screen. You can increase the size of the panels that you can see by going up to the squares above a particular panel. So, for example, you're looking at the live view. You can make that bigger so you can see the slides and the speaker when they come on. Also, down at the bottom, when you look down at the bottom, you'll see some little circles, and the circle which has a picture of a person in it with a kind of speech bubble is how you can ask questions through the Q&A. And I see we've already had some people putting questions in, and we'll come to the discussion of those after the talks in the panel discussion. So far, I think just over 800 people have joined, and we're expecting more to join. But I won't hold things up. I'll pass over straight away to Sam Welsh, who's based in the Coordinating Centre for UK Biobank in Manchester, who will describe the kind of mechanics of getting this study up and running and managing the samples during the 6 months when you were collecting them and providing them to us. So I'll hand over now to Sam.
Thank you, Rory. So hi everybody, good evening. My name's Samantha Welsh and I'm the lab manager at UK Biobank. So my focus of the talk this evening is going to be around the collection of the samples for this study and also what happened to the samples when they were delivered to our labs. So I'll start with a talk around the project setup, so how we set this study up so quickly with all the challenges that the pandemic brought. And then I'll follow on with what happened to your samples. So when you post your sample, what happened to it? What did we do in the lab? And then I'll end with some feedback to you as the participants about the quality of the samples that we received, because, spoiler, it was really quite excellent. So if you look at the timelines for this study, we had to set this study up really quite quickly. We wanted to do this as fast as possible so that we could assess as much of the pandemic as possible. So we only started talking about this study the day before lockdown. So the 23rd of March was the first project meeting. Within a month, we had funding approved. Less than a month after that, we were emailing the first batch of participants to register interest. And just 2 weeks later, we were sending kits out. So within 2 months of even starting to talk about the feasibility of doing the study, we were then actually live. And then the next 6 months, all of you participants kindly gave a sample every month, and we processed those samples in our lab. So to do this, we had to double the size of our lab team. So our team went from a team of just under 20 to 40, and every month those samples were processed. And as you know, towards the end of the last year, we finished the study. So last samples were sent off for testing just before Christmas. The results have recently been published, start of this month. As you know, the results were published. So setting a project up in a pandemic clearly brought challenges. As with everybody else, we had to get very used to using Microsoft Teams rather than sitting in a room talking to each other. So we had groups from all over the UK working together to support this project. We had a really small number of staff working on site to make sure that the lab was ready for us when we were starting to receive these samples. So we had sort of 3 or 4 staff working on site throughout. As you can appreciate, when we had all these calls, we met people that we'd not seen before, so colleagues, children, pets popped up now and again. I just wanted to give a bit of a background to my experience. One of my responsibilities was to have a look at the sample collection and what tubes and what lancets we would use to collect the blood. So this was one side of my desk, busy away collecting samples, and the other side, this was my son's workspace. So lots of challenges to overcome, but we got there, and that project did get set up in the 2 months that we had. So lots of questions that we had to answer to make sure that we were able to collect your samples and that they were going to be useful for this study. So at one point we had a spreadsheet with over 100 questions where we needed to define how we were going to collect these samples. So I've just given you some highlights of some of the questions that we looked at, answered, and then developed the process around. The first one always makes me laugh because at the very first day we talked about were we going to be able to send a phlebotomist to people's homes to collect blood, and then the next day lockdown happened, so that clearly went out the window immediately. So we moved to an at-home collection, and that's where we needed to then look at how easy was this going to be for participants to collect the blood. We wanted to make it as easy as possible, and we wanted to make it simple so that it wasn't frustrating for you to collect your blood. And we wanted to make it safe as well. So lots of questions needed to be answered, and this defined the process. As I said, one of the things that I focused on was the selection of the lancet. So that was what you used to create the kind of pinprick in your finger to collect the blood. I appreciate it's not the most comfortable thing. I did a lot of testing, so I know what it feels like. And we wanted to make sure that the lancet we picked was going to cause you the least discomfort, but be able to give you the volume of blood that you needed. So you can see at the top, these are just some photos I took from my phone around April last year. You can see the different types of lancet we've used, but also the volume of blood that I was getting from the different lancets. So the yellow lancet, for example, didn't hurt as much as the one that we ended up choosing, but it didn't provide anywhere near the volume of blood we needed. And it did feel quite frustrating to do that. Preparations for making sure that we could come onto site and store the samples and process them in a safe way. We had lots of things that we needed to think about. So we followed the government guidance, and we ended up implementing over 40 measures to keep the site safe. So this included 2-metre distancing, which we're all familiar with. So every workspace was measured out. We introduced doorbells so that staff didn't have to walk through between labs. They could use that to communicate with team members. We had walkie-talkies. We implemented perspex screens so that we could separate staff. Everybody had their own personalised goggles, lab coats. So everything was kind of made sure that staff were as safe as possible whilst working on site. And as you saw from the timelines, we started working back on site in May. So it was when the pandemic was still very much in the first wave, and lockdown was still present. So that was a little bit about the preparations. I'm now going to move on to talk around the sample life cycles and what actually happened to the sample after you posted it to us. So the first part of the process was for us to send the kits out to you. And that was actually done from our coordinating centre in Cheadle as well. So this picture at the top is Sandra from our admin team, and she is packing the samples and sending them off to Royal Mail, who would then deliver you to the participants the next day. So this is a lovely sunny day in May, first batch of samples going off. Then you as the participants were asked to collect your sample and post it back to us the same day. Biobank would then take over. So when the samples were delivered to us, we'd receipt them, so to confirm what we had. We'd recover the part of the blood that had the antibodies in that we were interested in measuring. And then the samples were frozen. And this was done on a daily basis. And then every week, the samples were then sent to a group at the University of Oxford called the Target Discovery Institute, and they did the actual antibody test. The results were then communicated back to Biobank, where we did the analysis of the results. So I'm just going to go a little bit more into the process of what happened in our labs. So for us, the first part of the process was to sort the samples. And the reason why we sorted samples was to make sure that the older samples were prioritised first. We wanted to make sure that there was the least amount of time as possible between you collecting your blood and it being in the freezer. So that's why we asked you to put the date and time on the outside of your envelope. We quickly checked that time and date, and we sorted the samples into the different crates. So you can see at the bottom of there, we have crates that are sorted by date and morning and afternoon as well. We did receive a really small number of samples that didn't have any date on, so those are the ones in the red crate. And they were always pushed through the lab first, just in case they were older samples. So the next part of the process was for us to receipt the samples. So the first part would be just scanning the outside of the envelope to make sure that we had a record that the sample had arrived safely back with us. The next stage was then to physically open up the contents of the envelope. And for that process, it was done in the safety cabinet. So that is what you can see at the bottom of the slide. Everything that was inside was scanned. So we had surveys and barcoded tubes. So all that was scanned, so we knew who had provided us the sample. And we had a record that it had been returned. At this point, I should say, for those people that added extra material in there for us, we had thank you cards, we had words of encouragement, positivity about the study, and that was really encouraging for the lab staff, particularly at the point when lockdown was very prevalent, and it was really helpful to boost morale. So thank you for those extra notes. So the next part of the process was for us to separate the part of the blood that we wanted to measure the antibody levels for. So that required us to spin the blood at quite high speed, and it then left us with the plasma, which is the part of the blood that has the antibodies in. So you can see in the middle of the page there, this is one of our lab team recovering the part of the blood that's got the antibodies in. The sample then went into a plate, and that plate was sent and tracked through our software at the bottom. So the last part of the process for Biobank was to freeze the samples. So the samples were frozen, as I said, every day. And this photo just gives you a view of what the bottom of the plate looks like. So each one of those wells is a sample tube. The samples were then shipped to the University of Oxford on a weekly basis. So I'm just going to cover a little bit about what the antibody test does and how it works. So we start with the black plate, which has 384 wells in it, so lots and lots of positions for samples. We have a layer on the bottom, which is each of the wells is coated in the coronavirus. We then apply the sample. So the sample, we think, will either have antibodies or not. So if we add the sample to these wells, we will see the antibodies bind if they're present. So the antibodies will do exactly what they would do in your body. They will go and attack the coronavirus if it's there. So in attacking in this situation means it's going to bind. So if we see that binding between the antibody and the virus, we can check if that's happened with a dye. So we apply a dye to it, and we'll see lots of colour if there's antibodies present. We end up therefore with a plate that's got some coloured wells and some wells that are not coloured, and that's measured by taking a photograph of the plate. that was about the process and what happened to your samples. I'm just going to end on giving you a bit of feedback on the quality of the results, because as Rory said at the start, we did see a really, really good response with this, and it's a really positive message to give to you as participants. So if we look at engagement to start with, so how many people stayed through the entire study? So we started the study with just over 20,000 people, and we ended with over 18,500. So 92% of people stuck with us for the whole 6 months. If we look at how that translates to samples, the first month, 93% of sample kits that we sent out were returned back. And even after 6 months, we hadn't deterred too many of you. 86% of people were still returning their samples back to us. So that gave us an overall return rate of 89% of samples. So really, really fantastic response. My final slide just covers more detail around the return and response rates that we saw. So as I said in the previous slide, 89% of samples were returned. But more importantly, almost every single sample that we had returned to us was sufficient for us to do the antibody test. So that meant that all that work we did at the start to make sure that the sample collection was right really paid off. 99% of the samples that we received went through for antibody testing. We also got surveys from almost all samples returned, which meant that we could link the data with symptoms that had been experienced just before. This is just before the sample had been collected. And then, as I said before, around sorting the samples that were oldest, we asked you to provide your sample on a very specific day. And the reason we did that was to manage the workflow through the lab. So 79% of people followed the guidance, followed the instructions and gave their sample on the exact day we asked, which meant it was much easier for us to manage the workflow and that we didn't have 5,000 samples one day and on the next. So that translated to us getting around about 62% of samples back on the day that we expected them. There was a slight delay for any samples maybe were posted later in the day for Royal Mail to get them to us. But by the day after we expected your sample to arrive, we had 93% of samples. So that really, really helped manage kind of the work that we had in the lab. Most people included the date that they collected their sample. So that really helped us look at how long samples were taken to get through to us. And then I just wanted to tell you a little bit about the volume of the blood that we collected. So I guess for you as a participant providing your blood, it may have felt like you won't be able to provide very much. I know it's quite difficult to get the volume that we asked for. But when we look across the entire study, we actually collected over 20 litres of plasma to be stored for the study. So it all added up in the end. And finally, just a note about participants' engagement with this study. We even had a few people drive to our site in Cheadle to make sure that the sample arrived. So they came with their sample warm out of their bin and gave it to us. So it just again highlights how engaged this group of people have been in this study and a massive input into making it a successful study. And I just want to end with saying thank you. So this is some of the lab team. We were able to get a photographer in towards the end of the study, just before we went into another lockdown. So this shows half of the team that worked on the study, and the other half were at home safely working, so that if they then could swap in with the other side of the team. I would have included a picture here of everybody who worked on the study, but we haven't seen each other for over a year. So for now, I just say thank you for everybody from Biobank and also for the participants for making this such a successful study. I'm now going to pass over to Naomi, and she's going to talk a little bit about the aims of the study and the results that we've gained from it. Thank you, everybody.
Thank you very much, Sam. So my name's Naomi Allen, and I'm the Chief Scientist for UK Biobank. Now, we're getting some reports that some people are having some trouble hearing us. So the technical people are working on it as we speak, and hopefully we'll be able to send you a message soon about to hear us. But if not, the webinar will be available for you to view tomorrow. So first of all, I just want to take a step back to tell you a little bit about the types of research that UK Biobank is enabling to happen to help fight COVID-19, and then obviously focusing on the serology study that you were a part of, and the results that we found and why they're important. So, as you all know, UK Biobank is a large research study of 500,000 participants recruited across the UK over 10 years ago now. And we collected a huge amount of data on you about your lifestyle, medical history, your physical measures. And we collected blood and urine and saliva samples from you. And we've undertaken measurements on those samples to look at genetic factors, biochemistry markers, and so on. And we're also following up the health of everybody through linkage to electronic medical records in order to enable research into why people develop certain diseases and other people don't. But what makes UK Biobank unique is that in addition to the vast amounts of data we've collected on hundreds of thousands of participants, the data set is easily accessible to approved researchers from around the world to perform health research that's in the public interest. And we have now over 19,000 researchers worldwide, both from academia and commercial companies, accessing these data for public health research. Over 2,000 research projects are underway, and there's over 1,400 publications using UK Biobank data, many of which have been published in the last couple of years. Because we've been continuing to collect vast amounts of data on you over the last few years, whether that's been web-based questionnaires, coming along to an imaging assessment, or wearing a physical activity monitor, and the fact that you're a fantastically engaged group of people who are interested in research, we've been able to mobilize our resources quite quickly to set up studies to help us to better understand the COVID-19 pandemic. And so UK Biobank is seen as an important piece of the scientific infrastructure to help us better understand. So one of the things we've been able to do is to release rapid updates of electronic medical records to the research community to enable COVID-19 research. So we've been able to release data to the community on the diagnostic antigen test data, so the swab test data, which we received back in March of last year. We're making these data available to the research community with data up until the end of January so far, with just under 15,000 cases of COVID-19 now notified in the cohort as a whole. We've also linked to death registry data. These data are available up until the early December of last year. There's over 700 deaths so far of confirmed or suspected COVID-19 in the cohort. We're also releasing data from hospital inpatient admissions, including critical care. These data are available currently up until the end of September of last year. And there's over 2,000 participants who have been hospitalized with COVID from the cohort so far that we know of. And we've also been able to release data from primary care solely for the purposes of COVID-19 research. And these data are available for the research community currently up until mid-July. And there's data again on over 4,000 cases of COVID-19. So these data are being used to enable researchers from around the world to conduct investigations into the association of lifestyle factors, underlying comorbidities, the types of medications used, and also how genetic factors influence the development of COVID-19 across the full disease spectrum. So about 700 different research groups are accessing these data and actively working on it. So far, there are about 150 publications to date on COVID-19 using the UK Biobank resource. And here's an example of some of the publications so far, looking at ethnic disparities in hospitalization for COVID-19, the influence on biochemical markers, and of course, how genetic factors influence the risk of why some people are more likely to develop severe COVID-19 compared with others. So in addition to that, we're also setting up a study to look at the longer-term health effects of the virus. And we're going to do this by asking all of the 500,000 participants to take a home-based antibody test if they would like to, in order to see whether they have antibodies to the virus or not. And having that data on the full cohort, together with all of the electronic medical record data that we have on you, will enable research into the magnitude and type of long-term effects, such as long COVID of the virus. And finally, we're also setting up a study to specifically look at the effects of coronavirus infection on internal organs. So about 50,000 participants have already attended an imaging assessment centre before the pandemic started. And we would like to invite about 3,000 of those individuals back, half of whom we know have been infected with the coronavirus, half of whom haven't, to have a second scan. And it will be the only study in the world that will have data on MRI scan images, both before and after coronavirus infection. So it will enable unique research to be performed about the potential effects of coronavirus on a whole range of different internal organs. And of course, last but not least, we've set up this serology study, of which you're a part of, and which I want to help share the main results with you here tonight. So we were asked by the Department of Health and Social Care in March of last year, it feels like a lifetime ago now, to set up a study to determine the extent of past infection in 20,000 individuals across the UK, and to see how infection varied by different population subgroups, such as whether it varied by age, sex, ethnicity, socioeconomic deprivation, and so on. Because we were able to ask you about any symptoms you've experienced in the month before your blood sample, we were able to find out what the most common symptoms are and to look at what proportion of the population were asymptomatic. And it's one of the few studies that's been able to collect blood samples serially on participants. So obviously we asked you to provide us with a blood sample every month for 6 months. And that data is enable us to determine how long antibodies persist in those who have been infected. So the first thing is to say is that over 116,000 participants and children and grandchildren signed up for the study when we sent out the invitations. And honestly, we were amazed at this response. And it meant that we had a really large pool in which to select the 20,000 participants to join the study, and we were able to make sure that they covered a large range of ages, of ethnicity groups, and socioeconomic deprivation. So we recruited about 10,000 existing UK Biobank participants who were aged between 50 and 80. And in order to increase representation amongst the younger adult age groups, we also recruited 10,000 of their adult children and grandchildren. And I have to say, it's the first time we've engaged family members to do research in UK Biobank, and we've been really overwhelmed at the amount of encouragement and response and take-up and interest we've had from the children and grandchildren. So I just want to say thank you very much to those who perhaps don't know as much about UK Biobank wanting to join this study. As you know, we mail to your home a blood sampling kit and a symptom survey every month for 6 months between early June and end of November last year. And as Sam said, the samples were sent over to their lab up near Stockport. They processed them, batched them up, and then they were sent to the Oxford Target Discovery Institute in order to do the assay to measure antibodies to the main spike protein of the virus. And then as the results were coming into us on a monthly basis, we then made those results available to the Department of Health and Social Care. So you know very well what this looks like. This is the symptom questionnaire and the materials, the lancet and the blood tube that we sent to you every month. And here are the characteristics of the study population. So of the 20,000 of you, as Sam said, just under 19,000 of you, so over 93%, provided at least one sample during the 6-month period. And about 90% of you returned a blood sample every month, which is a really fantastic response rate, and meant we were able really to look in detail at persistence of antibodies over time. And you can see here from this table that We were able to have a good distribution of participants between men and women across the different age ranges. And because we had such a huge response, we were able actually to oversample Black and ethnic minority groups into the study, so that we had relatively large numbers of Black and ethnic minority groups, because we know that infection rates in those groups are particularly high. And because of the large numbers, we were also able to select participants across the full distribution of socioeconomic deprivation as well. So overall, about 1,700 individuals had detectable levels of antibodies, at least in one of their samples during the study period. This shows the seroprevalence over time, so the proportion of participants with positive antibodies from June to November. What you can see is that the proportion of the population with positive antibodies was about 6.6% in June, rising to just under 9% by the end of November. And you can see a clear increase in the seroprevalence from September onwards, obviously, which corresponds to the start of the second wave of the virus in the UK. We found that the proportion of the population who had antibodies to the virus, who had evidence of previous infection, varied substantially by region, being highest in London at just under 12.5%, also relatively high in the West Midlands and the North West at over 9%, and being lowest in Wales, the southwest of England and Scotland at under 6%. We also found substantial variation across age groups. So the proportion of the population who had positive antibodies to the virus was highest in those under 30 at about 13.5%, and lowest in those over the age of 70 at just over 6.5%. Again, seroprevalence varied markedly by socioeconomic deprivation, being highest among those who lived in more socioeconomically deprived areas, being over 11%, and lowest among those who live in more affluent areas at 7.8%. And finally, when we looked at by ethnicity, again, you can see substantial variation in past infection between different ethnic groups, being highest in those of Black ethnic minorities at over 16%, and compared to white ethnic group at 8.5%, and Chinese ethnic minority at 7.5%. When we look at antibody changes over the study period, we found that this increase from June to November was similar between ethnic groups, same in white groups compared to Black ethnic minorities. But what we wanted to understand was, why is it that Black ethnic minorities seem to have higher rates of infection compared to the white ethnic groups? And the data that we had, it isn't on age, socioeconomic deprivation, location of residence, didn't seem to explain that difference. Which is why we've recently sent you a questionnaire asking about how many people live in your household, what type of job do you have, how often do you face seeing the public, do you use public transportation, and so on. And these data will help us to hopefully better understand why Black and ethnic minorities have high levels of previous infection compared to white ethnic groups. So moving on to symptoms. So if you remember, you recorded all of your symptoms, a whole range of symptoms were asked in the 4 weeks previous to your blood collection. And what we found were, of those who had positive antibodies to the virus, about 43% of those who were positive also reported a loss of sense of taste or smell, which is by far the most common symptom that was reported. About 28% of you who were positive reported having a fever, and a similar number reported having a persistent cough. And of course, these are the three main COVID symptoms, any of which will make you eligible for a test and trace. Interestingly enough, every single symptom that we asked about, whether it was nausea, shortness of breath, fatigue, muscle aches, and so on, they were all reported more frequently in people who had tested positive for the antibodies. But other than the loss of sense of taste or smell, there was no single symptom that really stood out that was predictive of having been previously infected. Interestingly, what we found was that 40% of those who had antibodies to the coronavirus did not report any of those 3 classic COVID-19 symptoms. And nearly a quarter of people who had antibodies, 24%, were completely asymptomatic. It had no symptoms at all. And so what this means is that 40% of the study population who had been exposed to the coronavirus didn't have any of the classic symptoms and therefore not being tested and therefore not self-isolating. So because we were able to collect samples from them every month for 6 months, we were able to look at antibody persistence. And in fact, we've been only one of the few studies who've been able to do this so far. And what we found was among the 700 or so individuals who had antibodies at the start of the study, so in May and June of last year, almost all of you, 99%, were still positive 3 months since you reported the onset of symptoms or your PCR test, and 88% of you were still positive 6 months later, which is pretty good news, because it shows us that once you have been infected and you've produced an antibody response, those antibodies are going to hang around for some considerable time. We're currently undertaking some analyses now to actually measure the quantitative titer levels. So rather than just having data on whether you're positive or negative for antibodies, we're actually measuring the precise quantitative amount. So we'll be able to do some analysis to look at how antibody levels wane over time and whether that differs by age, ethnicity, whether you've had symptoms, and so on. We've done some preliminary analyses of this, looking at antibody persistence over time by age and ethnic group. And whilst you might not be able to see that quite clearly, the take-home message is the lines look very similar. So it seems to suggest that antibody persistence is remarkably stable across different ages and across different ethnic groups. So why are these findings important? So, as I've said, very few studies have been able to look at antibody persistence every month over a period of time. But the few studies that have done, particularly those in Iceland and other studies in the UK, have also shown that antibodies can persist following natural infection for several months. And studies in UK healthcare workers have also shown that those who had been infected during the first wave, the likelihood of reinfection was very low, up to 5 months later. It wasn't zero, but it was very low. So while our findings, we cannot really be certain about how our findings translate into immunity for future infection, what these findings do suggest is that if we know that antibodies persist for the vast majority of people for about 6 months, and we know that the likelihood of reinfection is low across the same period of time, it does suggest that people may be protected for at least 6 months following natural infection. So obviously the big question now is, well, what about longer persistence? We've been able to do this study in 6 months, and obviously we would need another sample to determine how long such protection is likely to last. So if we would like to send out another sample to you over the next couple of months, we will get in touch with you, and it would be great if you could help us out once again by providing a final sample. So I just want to end here by just thanking you for your really valuable contribution to this really important study, and it's really helped us to gain a much better understanding about the persistence of antibodies following infection. So I'll leave it there, and I'll hand over to Sir Jeremy Farrar now.
Thanks, Naomi. I hope everybody can hear me and see me. I can still see you, Naomi, so I hope everyone can hear me. It's a great pleasure to join this. I'm Jeremy Farrar. I'm the head of the Wellcome Trust, which is incredibly proud to be a supporter of of Biobank and has been since its inception. And it's fantastic to hear these studies. It almost brings a tear to my eye, because I have to say, as sitting outside the Biobank study itself, I just think this is the most extraordinary study in the world. It is giving so much information to inform what we do within Biobank and all the volunteers, and in this particular case, of course, all the family members as well. But in the context of COVID-19, it has been absolutely invaluable in terms of informing government policy, in offering ways to prevent infections from spreading in the community, and also informing whether people who have been infected are likely to be protected against future infections. So just an absolutely extraordinary study. It's really difficult to put into words just how important it has been. And just to thank everybody that's on this call, all the volunteers from Biobank, but I'd also like to thank the teams at Biobank. You've heard from Rory and Sam and Naomi, but behind them, of course, is an enormous number of people that make this happen with incredible professionalism and dedication in what's been a very, very difficult time. I've been Director at Wellcome now for 7.5 years, but actually, slightly bizarrely, my own personal professional background is in emerging infectious diseases, and I've lived in Vietnam for 18 years and actually lived through and was responsible for doing a lot of research on SARS-1 in 2003. It's bizarre to now be back dealing with another SARS-type virus in 2021. And the truth is, we're going to see more of these sorts of disruptive, chaotic, frightening. I remember still, as a doctor working through SARS-1 many years ago, it's a very terrifying thing to be part of, and it's a very terrifying thing to deal with as a community when an infection is spreading through that you're not used to dealing with. And there is great uncertainty. There's great uncertainty in what to do as an individual, but there's also great uncertainty in what to do as a country. And of course, the UK has suffered very badly during COVID-19. But the only way of dealing with that certainty is to do research, to learn, to understand more, and to do what you can to try and bring a pandemic like this to a close. And I do think that there is light at the end of the tunnel. The coming of the research has led to the development of vaccines and diagnostics and treatment now. And although it seems as though the tunnel is very, very long, I do think we're coming to the end of it. But we're only coming to the end of it because of the research that Biobank and others have done that points in the direction that actually there is immunity, that after you've been infected, it's highly likely that you do have protection, certainly, as Naomi said, for a few months and maybe for much longer. That has allowed us to make vaccines that will protect us even better. It's allowed us to make treatments because we understand how the virus works and the immune response to it. And it's allowed us to develop diagnostic tests that measure those antibodies that Sam and Naomi have talked about. So we couldn't have got there. We could not have got there in the last 12 months without the information that's come from Biobank. And that's a tribute to everybody that's been part of it. It's a tribute to the way it was set up originally, and it's a tribute to the many, many volunteers and families that have taken part in it. And the world, let alone this country, owes you a huge debt of thanks for what you've done to bring at least some point in the future, and I hope soon, light at the end of what has been a very, very dark period in human history. So thank you very much. It shows the power of working together. It shows the power of trust and communication between people that are volunteering in studies and those that are running studies. That's a tribute to both the volunteers here on the call and their families, and also to the team at Biobank. So thank you very, very much. It is the most extraordinary study in the world, and it's been, I think, the most informative in terms of helping us see through this pandemic. So it's a privilege to join the call tonight. Thank you very much indeed, and very happy to take any questions if there are any that I can help answer in the role I play in this. And so hand back, I think, to Rory for the at the end.
Thanks very much, Jeremy. And actually, it does allow me to, on the behalf of UK Biobank and the participants, thank the Wellcome Trust and the Medical Research Council for having had the vision in the beginning to set up UK Biobank, and it does allow us to also address one of the questions, which was, is UK Biobank set up to make a profit? And the answer is no, other than in the sense of profiting knowledge. It is a charity funded by the Medical Research Council and Wellcome Trust. British Heart Foundation, Cancer Research UK also help, and the National Institute of Health Research, so the NHS. And their generous support has allowed us to create this extraordinary resource, which, as Naomi has said, is being used by researchers all over the world. So I think we'll go into the questions, and there have been a lot of questions coming in. One that a number of people have asked is, can we get our results back? And the quick answer is no, but I'll explain the reason. And that is the method we used for collecting this sample had not been approved for clinical use by the medical health, the MHRA, the people who controlled drugs and testing. So we were able to do it for research purposes on the basis that the results would not be fed back to individuals, and that's the ethics approval that we've obtained. Having said that, in the last couple of days, we've been asked to provide the experience from doing this study to the government so that it can be used for testing of people in the population. So Samantha has been providing all of the experience of collecting the samples and how much sample we got and how well that worked to help the team actually in Oxford who were doing the laboratory testing to get that approval from the MHRA. So I'm sorry we can't give you back the results, although if you do take part in the study that Naomi mentioned, where we will send out a self-testing kit for those participants in UK Biobank, I'm afraid not the children or grandchildren who are here today, then you will get a result because you will see it in front of you and you will be telling us that result. But that leads into another question that a number of people have asked, and it's a question to Naomi. If people have been vaccinated, then can you determine whether their antibodies are due to infection or to the vaccine?
That's a really good question. And at the moment, with these lateral flow tests, which are the home-based antibody kits that we'll be sending out to participants who want to take part, the answer is you can't distinguish. The lateral flow test doesn't distinguish between antibodies produced from a natural infection to that produced from a vaccination. But however, having said that, there is technology that does now exist on a large scale that can differentiate between antibodies produced naturally from an infection and those produced from a vaccination. So in an ideal world, what we'd want is to collect another small blood sample from each and every one of you, get that measured in a lab to determine whether those antibodies are from a natural infection or whether they're actually from vaccination, because that's a very important distinction.
So to be clear, if we were to get another sample from this study in a few months' time, that sample is coming back to a laboratory where they would be able to distinguish. But when you send out the self-test, if people have come up with a positive result, that could be positive because they've had infection, or it could be positive because they've had vaccination. But there is a way of distinguishing by getting a small blood sample from those individuals, from the positives. And right. Another question to you, Naomi. So someone was asking, well, if I've not had any symptoms, was there much point in me giving you a blood sample? I didn't have any problem. So can you kind of go into the, and even if you didn't have antibodies, why are you useful if you like?
Yeah. Oh, it's hugely important for us to get as many samples from those who turn out to have positive antibodies and those who haven't been infected, because without information on who hasn't been infected, there's no way we can obtain information about the proportion of the population who has been infected and what symptoms they may have had. So it's a real fallacy to think that, oh, just because I wasn't infected, my data was useless. It is just as informative as having data and samples from those who have been infected.
So there was also a question as to why some people were selected and others not. I mean, I know that there were way over 100,000 people who volunteered to take part, and someone wrote, you know, my mum is in UK Biobank, but she didn't get selected and I did. And somebody else said, both my wife and I volunteered, but only my wife got selected, I think it was. Why was that? And how did you what was the selection process that you were trying to achieve?
Yeah, well, that's a really good question. We, as you know, we had a huge response and expressions of interest to join the study, and we selected participants to join who across a wide range of different characteristics. So we wanted people ranging from their 20s through to their 70s across all strata of socioeconomic deprivation, and we were able to oversample Black and ethnic minorities, as I said before, because we knew that infection rates were high in those groups. We specifically didn't want to invite people who lived in the same household to join the study, because we know that the likelihood of co-infection within a house is very high, like 80 or 90%. And so we only wanted one participant per household to join the study, because that would give us a more accurate representation about what was happening across the UK.
Thanks very much. Sam, can you talk about the magic you did in the labs, in the sense that a lot of the participants have mentioned that they found it difficult to get enough blood or get the blood up to the line in the tube. Were you able to get sample from pretty much everybody that provided a tube and sent a tube in?
Yeah. So yeah, I've seen a few of those questions come through. So absolutely, we asked for half a mil of blood, and we knew that wasn't going to be possible in all cases. But that would give us the full volume that would allow us to do the antibody test, but also to store around about 0.2 mil of blood for further testing. So even those samples that you sent to us that had a few drops of blood, we were able to recover enough for the antibody test. It just meant that we weren't able to store as much plasma that we wanted for the downstream testing and anything we might want to do in the future. But as I said in my talk, 99% of the samples that were received were absolutely viable for the antibody test. When we look at what we've been able to store as a backup in the future, if we want to return to it, it dropped down to maybe 50% of samples had the full volume that we asked for, but that didn't impact the quality of the results for the antibody test.
And what about samples collected at different times of the year, particularly on hot days and delays in the post and things like that?
Yeah.
Did you get any feedback from the lab on that?
So we saw absolute phenomenal quality of results, and actually the failures were really, really low. So 0.4% of samples failed, which was really good for this assay. So we didn't see any peaks in the summer. So we saw consistent failures kind of throughout the year. And yeah, the quality of results didn't seem to be impacted by delayed samples coming through. So our average was around 40 hours from the point of collection to getting it into the freezer. And we looked at just how variable the results were and if we saw more failures for old samples. And actually that didn't seem to impact, even though that was something at the start we were keen to minimise.
And just another follow-up on the samples, Sam. We've tested the antibody levels, but you mentioned sample being stored. What was stored? And in particular, a couple of people asked questions about whether one can look at the immune response of the cells as compared with the antibody levels in the blood.
Yeah, so I saw that question. So we've stored all of the plasma that we were able to recover from each of the samples. So we have up to 200 microlitres, which is just 0.2 mils of plasma. And we've also, for those people that we don't already have a DNA sample for, we have started to extract DNA from the samples that were provided. So that will allow us to do DNA sequencing. We unfortunately didn't collect the red blood cells. We were limited in the space and the amount of samples we were able to collect. So we made a decision to collect the plasma as a priority.
And someone has asked about different coloured stickers on the back of forms, and also why were the Lancets sent back to you?
Yep, so the different colours, so that was to do with the operators that were actually packaging up the kits. So this was an external company that compiled the kits for us, and they used coloured stickers to identify the different operators that had put the kit together. So it was a QC step. The other question was about Lancets. So that was more of a safety point. So we didn't want you to be throwing the Lancets into the kind of household waste. They have very small blades in them, and they had a very small amount of blood on as well. So they are technically classed as a medical sharp. So we worked with Royal Mail to understand how best to do that and whether it was safe to return those samples through the post. And that it was agreed that it was safe to do so in the way that we asked you, to put them in that clamshell. So what happened when we received them in our lab is we just threw them straight into the clinical waste in a safe way.
And Jeremy, a question for you. I certainly don't know the answer to this, but people are interested in vitamin D. Do you have any thoughts on vitamin D and the evidence for it being protective against infection or more serious symptoms?
Yeah, I think I put vitamin D, Rory, and the question, I saw the question in the category of a number of different things that have been suggested over the course of the last 12 months, which may play a role either, as you say, in prevention or indeed in potentially in treatment. And I think the answer for all of those, in my view, including vitamin D, is the case remains unproven at the moment. Those of you who remember 2020 will remember a number of other claims, sometimes even from presidents of some of the richest countries in the world, claiming all sorts of things worked or didn't work. I think the crucial thing is to demonstrate and provide the evidence. And the recovery trial, which colleagues of Rory run from Oxford and is going on across the whole country, tries to do that. And I think alongside Biobank has perhaps been the two critical studies that have provided evidence on which we've learned so much about COVID, and which is saving lives today in this country and around the world. So I think the jury is still out on vitamin D, but they are part of other studies going on in other research groups beyond Biobank.
And Jeremy, there's some questions also asking if you might expand a little bit on your comments about what the future holds in terms of the increasing number of pandemics in the future. Why is that the case, and what do you think can be done to ameliorate that?
Yeah, I certainly don't want to be alarmist, but if you just look back in the last 20 years to really 1999, so the last 20 years, there's been a series of at least 5 or 6 major either regional or global events, some of them more serious than others. Of course, this is by far the most serious. But all of those have really been driven by issues that are very relevant to the world we live in today. Many of those infections started in animals. They've come about because there's a changing interface between the animal kingdom and humans. Ecology is changing how animals link with humans. Urbanization means that once an infection jumps across into the human population, it can then spread very rapidly in huge cities, in Wuhan in this case, but there have been many other cities. And then, of course, you can fly around the world in 24 hours. And so the changing ecology, urbanization, change of land use, change of the way humans and animals interact has led to a very large number of warnings in the last 20 years. And all of those drivers remain true today and will remain true in the years to come. So I think we'll undoubtedly see more frequent and more complex epidemics in the years to come. And we have to be better prepared for them than we were for COVID-19. And having studies like Biobank is really important in that, because you can't establish this sort of infrastructure and trust between the studies and the volunteers unless you've been running them for a long time. And that's why what you have before a crisis hits is so important in your ability to respond to it.
And can you comment on, again, a question about what Naomi was showing about the antibody levels following infection and how that might relate or might be relevant to the persistence of immunity following vaccination in terms of duration?
Yeah, I think Naomi explained it very well. For many infectious diseases, the level of antibody that we can measure in your blood is a good predictor of whether you are protected against that infectious disease. It's true for measles, it's true for tetanus, it's true for many, many infectious diseases. We don't yet understand what that level of antibodies is. That means if you have those antibodies, you are protected. That's called the correlate of protection. And we desperately need to understand that. It's one of the most important unanswered questions at the moment. And again, just to give praise to Biobank, it's one of those issues that can be answered by studies like Biobank, because you have blood before the pandemic, you have it during the pandemic, and hopefully you'll have some blood after the pandemic. And it's those sorts of studies from people who were infected and those that aren't and may go on to get infected in the future that will tell us what level of antibodies in the blood actually give you protection. That's important to understand as an individual, as a community. It's also absolutely critical to the development of new vaccines.
Thank you very much, Jeremy. And I think that's also true of the people who were the 50,000 people in UK Biobank who've been imaged in the past. And Naomi described how some of them who we found have got antibodies, and some of those who haven't got antibodies will come back for repeat imaging, because it will be the only data in the world where one has pre and post-infection imaging data that one can look at changes, and those data will be made available. I should say all these data are made available in a de-identified way to researchers, so that no one can be identified, but they are being made available to researchers everywhere in the world. I'm just going to round up with one last question to Naomi, which is about the different rates of infection in different populations, which you described. I think somebody was interested in how the rural-urban split. Other questions around whether there are enough people in different socioeconomic groups, particularly the lower socioeconomic groups, and what your thoughts are, or indeed, Jeremy, your thoughts are, as to the differences in different groups of individuals. So, Naomi,
yes.
perhaps.
Yeah, well, so we know that the proportion of the people who had evidence of previous infection was higher in those who live in urban areas compared to rural areas. Same for, ethnic minority groups and socioeconomic deprivation. We did have, because of the huge numbers of people who were interested in joining the study, as I've said before, we were able to select individuals across the full range of socioeconomic deprivation, across different ethnic groups, across different urban, rural conurbations. So we had sufficient numbers in all of those categories to be able to compare different rates of antibodies across those different groups. So while the proportion of people from Black and ethnic minorities, for example, was much lower than those from white ethnic groups, you still had substantial numbers in each of those groups to give you fairly robust estimates of how the rates of natural infection varied between the two different groups.
So, Jeremy, perhaps I could ask you to kind of finish off on that. You've looked at the data coming from UK Biobank, but also other data that's being fed into groups like SAGE, which advise the government that you're clearly closely involved in. are there messages coming out as to why particular groups are more likely to get infected? And a question that comes up, does that help to identify ways to protect those particular groups?
Yeah, it really is very important, because although the infection is clearly worldwide, it hasn't affected everybody equally. Certain communities within every country have been more likely to be affected, and Naomi has drawn attention to some. I think increasingly the view is that this is related not just to the virus and not just to the person, but also to the environment in which everybody is living in. And the urban-rural divide is very stark. It's true as well in other countries. And I believe that is related to the density of population, people living in multi-generational families, living very closely together, and having different social contacts. It's critical to understand that, because as you, for instance, roll out vaccine campaigns, as you advise about how to prevent getting infection, and then, of course, how do you make sure that people of all communities have got access to the clinical care they need when they need it, it's really important to understand who's at most risk, who's at less risk, how do you allocate the resources to be able to give the best possible prevention and care to those that need it. So we're within 12 months of a brand new human infection. None of this was known even 6 months ago, and we're only gaining insights of that from studies such as Biobank, which is telling us not just to observe what's happening, but also to explain it through those multi-generational families, density of populations, and age factors and others that are driving at-risk communities, and both for getting illness, but also getting sick if they do get infected.
Well, thanks very much. I'm sorry I let it run on a little bit. There were so many questions, and I apologize if I've missed yours. I've tried to group them as far as I could. I want to thank Jeremy for joining us, Naomi and Sam for describing what they've been doing, and the huge amount of work they did do along with their teams for this study, and particularly to thank all of you. I think over 1,100 people joined this call, so it's very wonderful for us, actually, to know that you're interested not only to take part, but interested in what's come out of it. And we're grateful to you and the other 19,000 or so who joined this study, and of course the remaining 500,000 in the UK Biobank cohort who are contributing in other ways. But thank you very much. And if you do want to watch the presentations again, I know some people had a little bit of trouble at the beginning with the sound, but I think that was largely sorted out. Then it will be online tomorrow. But again, thank you very, very much for joining us this evening, and have a good evening.